My topic is the total hip replacement in the setting of femoral deformity. The definition of the femoral deformity here is the variation of anatomy that require advanced surgical technique and special instrument or implant. The goal of the reconstruction is to avoid the femoral deformity, force the suboptimal implant position of fixation, which subsequently will affect the hip function and longevity. The Berry classification describes the femoral deformity based on the location, geometry, and etiology. This classification is useful to help guiding the treatment. All these factors are interrelated. However, the choice of surgical technique and implant is mainly determined by the exact location of the deformity. In detail, the location divides into greater trochanteric area, femoral neck, metaphysis, and diaphysis area. The deformity of the greater troch deformity may be caused by idiopathic, post-traumatic, or post-surgical. The trochanteric overhang can obstruct the entry point and force your stem into a varus malposition, and then can lead to a femoral canal perforation or troch fracture. In that case, you may avoid those complications by performing the trochanteric osteotomy and put the stem correctly. The deformity of the femoral neck may be a crux brevis that is common in leg arthritis. The typical problem for this deformity are the difficulty of exposure and stiffness of the hip joint and shortening of the hip. The coxa the etiology can be congenital or acquired. The key of reconstruction here is to restore the femoral offset. Otherwise, you may encounter with the hip instability or lengthening the hip. Performing hip replacement for the coxa is recommended to do a little bit low neck cut and implant with a high offset stem, as shown in this picture. The coxa valga. The most common situation in our practice is a developmental dysplasia, which is the femoral anatomy present with excessive anteversion, coxa valga, and small canal. A cemented stem can address the deformity, but with the risk of the stem failure, because a typical patient is younger than the patient who has an OA hip. So there are several options for uncemented stem. The first option is a proximal fit. This technique not allow you to correct the excessive version, so you may risk with the anterior dislocation. Otherwise, you may use a smaller stem and remove more bone on the posterior medial area of the femoral neck and then put your stem in less anteversion. A second choice, you may make a lower neck cut and then you already excite the deformity and just put your stem, maybe put in a slightly valgus to restore the offset of the patient. Another option, use of the spatial distal fit implants such as the Wagner stem for DDH. This stem can bypass the proximal deformity and get fitting distally, and also can, with the conical shape of the stem, you can adjust the version as well. A modular stem is another option that will allow the surgeon to fit the proximal and distal part of the femur separately, and then will allow the surgeon to adjust the version of the femur. Incro type 4 or Hatophylakitis type 3 with a high riding hip dislocation, the subtrochanteric osteotomy may be required to shorten and restore the hip center. This osteotomy can also correct the abnormal version. The modular stem is also benefit in the combination with the subtroch osteotomy because of its versatile option to fit the proximal and distal part of the femur separately. The metadiaphysis area deformity, dislocation of the deformity is more challenging. Various causes, but the most common is from the prior intertrochanteric fracture or prior corrective osteotomy. The practical approach to this deformity categorized into three groups: a very proximal, a subtroch area, and distal part. This is an example of the patient who has a proximal deformity. Option 1, you can use an implant that bypass the deformity and get the satisfactory position of the implant. as shown in the picture. Or the option 2, you can excise the deformity and replace it with the metal. For the distal deformity, most can be ignored if there is sufficient room to place the stem. In this case, there are the deformity at the proximal and the distal, but fortunately, we can pass the conventional stem through the proximal deformity, and the distal lesion is far from the stem. The subtroch level deformity is the most difficult because it is too proximal to ignore, and it's too distal to bypass. So most of the subtroch deformity may require the corrective osteotomy. It is recommended to perform the osteotomy at the deformity level, maybe in a transverse, step cut, or chevron fashion. It depends. Uncemented stem is preferred to get the fixation at the proximal and distal fragment, and the modular stem may be an excellent option for this situation. The short stem and hip resurfacing may be another possible option to avoid the morbidity of the femoral osteotomy for the subtroch deformity. The short stem may also be very useful when you encounter retained implant distally, as shown in the picture. And some short stem design seem to have a very good clinical outcome, so you can rely on that. Hip resurfacing is another alternative option. However, this technique has some drawback and gaining less popularity. These are examples of the patient who retained the endonail for 30 years. And placement of the short stem is maybe questionable right here, and the hip resurfacing may be a good option. However, I decided to perform an osteotomy to remove the endonail and implant with the conventional tapered and cemented stem. Another situation that becomes more common in nowadays of our practice is the fixation failure. The implant and fracture itself may cause some deformity at the metadiaphysis area. This issue will soon coming up in an excellent talk by Ajahn Saladet, so I will leave it to him. The poor operative planning seems to be a critical pitfall for hip replacement and femoral deformity. This paper proposed a useful 4-step for the pre-op template. The first step is to identify the anatomy landmark as shown in the picture. Second, evaluate the quality of the radiograph, mainly on the positioning of the hip, and avoid the magnification error by calibration or by use the digital template. Step 3, define the mechanical landmark such as the hip rotation center, femoral offset, leg length discrepancy. Is it important to plan for restoration of the original anatomy and hip mechanic? If the original hip mechanic cannot be restored, is it important to compensate for the anatomic relation between the greater troch and the pelvis? The greater troch and pelvis to get a proper tension of the gluteal muscle. The last step, select and position your implant on the template. There are several possible complications in this situation: malposition, fracture, and something else. So intraoperative fluoroscopy is always be your good friend. In conclusion, the majority of femoral deformity can be managed with a one-stage surgery. You need to understand the pathology and classification, the surgical strategy for the specific circumstance. In the troch overhang, you need to avoid the varus malposition of the stem. Coxavira, the hip is stiff and shortened. The coxavara, the hip offset, will be an issue. The coxavalga, you are facing with the version problem. The most difficult metadiaphyseal deformity, you can ignore the distal deformity that not interfere the implantation. You can usually bypass the proximal deformity The subtroch deformity may require a corrective osteotomy, alternatively with the short stem or hip resurfacing. The preoperative planning is very, very important. Thank you.